Good morning, students. Today we will see the solved question paper of Obstetrical and Gynecological Nursing of 2016 scheme, which was conducted in January 2022. The first question is the long essay. Enumerate the causes of GDM, list the complication of GDM, and discuss in detail about management of GDM during pregnancy. An abnormal carbohydrate metabolism with the first onset during present pregnancy is called as gestational diabetes mellitus, otherwise in short we call it as a GDM. Maternal complications during pregnancy include abortion, preterm labor, infection, increased incidence of preeclampsia, polyhydramnios, maternal distress, diabetic retinopathy, diabetic nephropathy, and ketoacidosis. Maternal complications during labor include prolongation of labor due to big baby, shoulder dystocia, perineal injuries, PPH, operative interferences. Maternal complications during puerperium include puerperal sepsis, lactation failure. Fetal complications are macrosomia because maternal hyperglycemia will lead to hypertrophy and the maternal hyperglycemia will lead to increased blood glucose level in the fetus. That in turn will lead to hypertrophy and hyperplasia of fetal islets of Langerhans, which leads to increased secretions of fetal insulin. So, this increased insulin will help stimulate carbohydrate utilization and fat deposition. And increased maternal free fatty acids leads to increased transfer of fetus that leads to acceleration of triglyceride and adiposities, then congenital malformation of the baby. Management of GDM during pregnancy include pre-pregnancy counseling. That means the patient is already having diabetes mellitus. In those cases, we need a pre-pregnancy counseling. And during pregnancy, GDM was present the first trimester, her HbA1c or glycosylated HB estimation will indicate her diabetic status. Normal level should not exceed 7%. And USG in serum alpha fetoprotein will help in detecting malformed embryo. MDP indicated in severe diabetes mellitus complicated by nephropathy and retinopathy and in the fetus is malformed. Excessive vomiting should adequately treated. Urine culture, vaginal smear is necessary to identify the causes. Then in second trimester, women should be admitted for adjustment of drug dose and diet control. Diet should consist of 30 kilocalorie per kg body weight daily and 200 gram of carbohydrate and plus protein and fat. Frequent blood sugar checking should be done. That means the diet consists of 30 kilocalorie per kg. Oral hypoglycemic drugs cause placenta and cause fetal hypoglycemia. Therefore, insulin which does not cross placenta is administered usually in case of GDM. In third trimester, the woman should be hospitalized in case if she develops PIH, hydramnios, or renal infection. Thiazide drugs can cause hyperglycemia and should not be used. Adjustment of insulin dose is required in third trimester because the rising level of placental hormones antagonize the insulin's effect. After 34 weeks, the hospitalization is necessary. Apart from maternal monitoring of blood sugar, fetal monitoring becomes essentially now. The fetal position, size of the fetus, presence of hydramnios, less than sphingomation ratio of 2 or over, less than level of 3.5%, which ensure a good respiration at birth, non-stress test twice weekly, biophysical profile is effective, non-invasive and quick method of assessing fetal well-being and does not away with amniocentesis to essentially estimate LS ratio. And pelvis should be reassessed and CPD should be ruled out around 36 to 37 weeks of gestation. Bishop's score noted in view of possible need for induction. Diet. Diet modification is the main treatment of GDM. The diet is placed on standard diabetic diet. Dietary counseling by a registered dietitian is recommended. Exercise. Exercise decreases the need for insulin in overweight women with GDM. Monitoring of blood glucose level. The frequency and timing should be individualized for each woman. The medications for controlling blood glucose levels and fetal surveillance women with hypertension, prior intrauterine death, suspected macrosomia, or those who require insulin for blood glucose may have twice weekly non-stress tests beginning at 32 weeks of gestation age. Short essays. Discuss in detail the physiological changes that occur during pregnancy. The respiratory changes include elevation of diaphragm by 4 cm at term. Hyperventilation leads to compensated respiratory alkalosis. Oxygen consumption increase to 30 to 20 to 40 percentage. Urinary system, there will be dilatation of ureter and pelvis. Urinary frequency will increase initially. Stagnated urine is a good medium for bacterial growth, so frequent emptying of bladder should be done. And the muscle layers of uterus, the endometrium is named as decidua, and the myometrium or the muscle layer is arranged, outer one as a longitudinal layer, middle layer is arranged as a crisscross fashion, the inner one is as arranged as circular fashion. Perimetrium, which is a continuation of peritoneum. Weight of the uterus is increased to 62, thumb means 1 kg. The size increased to 13, 23 and 20 centimeter. The painless uterine contraction will start from 16th week, called as Braxton Hicks contraction. Change in the uterine shape. At 12th week, it comes out of the pelvis. 24th week, it reaches at umbilicus. And 28th week, midway between syphisternum and umbilicus. 36th week at syphisternum, and 40th week, 4-finger bed below the syphisternum. Blood supply to the uterus is increased to meet the growing need of the fetus. There will be Hagar sign, Osiander sign, Chadwick sign, Giacomo sign, and Goodell sign. Cervix secretions become copious due to effect of progesterone. The length of cervix remain unaltered. And the heart increase in the size because of increasing of workload. Cardiac output will be increased from 5th week and reaches maximum by 30 to 40 week. There is no change in BP. Supine hypertension syndrome may occur. Cardiac output increase due to meet the demand of oxygen. Uterine blood flow will increase from 50 ml to 750 ml at term. Hematological changes include blood volume increases by 40 to 50 percentage. RBC and HB will be increased. Physiological anemia will develop. Hemodilution will happen. Blood coagulation factors will increase. Blood components will be increased. Iron absorption and iron binding capacity increases. Erythrocyte production increases. Leukocyte will be increased. Breast enlarges. There will be trickling sensations. And colostrum will be can be expelled from 16th week onwards. The cholasma gravidarum or mask of pregnancy. Then linea nigra stria gravidarum on the abdomen. Patient will be gaining the weight around 11 to 12 kg if normal BMI, and if it is BMI is less than 19, patient can gain up to 19 kg, and if the BMI is more than 29, means not more than 7 kg. And GI system become congested. There will be decreased mobility, cardiac spindle relaxed, nausea and vomiting will occur, delayed gastric emptying, and skeletal system relaxation of the pelvic ligaments, widening of symphysis pubis, progressive lordosis. Pituitary gland, FSH and LH will be stopped, serum prolactin will be produced by anterior pituitary. At term, pituitary will produce and oxytocin, SCTH and CRH will be increased. The thyroid gland will enlarge because of increased BMR. Parathyroid gland will be increased because of the increased calcium metabolism. And third question is recent advances in infertility management. The most common choice of treatment are in vitro fertilization, artificial insemination. Frozen embryos means the embryos may be taken from an individual and stored for later use. Gamete intrafallopian transfer, a mixture of woman's egg and sperms are placed in the fallopian tube during laparoscopy. And zygote intrafallopian transfer, the mixture of in vitro fertilization and gamete intrafallopian transfer. Then tubal embryo transfer, intracytoplasmic sperm injection, that means the sperm injected directly to the eggs in the laboratory. This technique also applied to oozy donation and gestational carriers. Short notes. The first one is role of nurse in obstetric. Obstetrical nursing, also called perinatal nursing, is a nursing specialty that works with patients who are attempting to become pregnant, are currently pregnant, or have recently delivered. Obstetric nurses help to provide prenatal care and testing, care of patients experiencing pregnancy complications, care during labor and delivery, and care of patients following delivery. Role of midwife. First, a midwife must be able to give necessary supervision, care and advice to a woman during pregnancy, labor and postpartum period. They should be able to conduct deliveries on her own responsibility and to care for a newborn and the infant. This care includes preventive measures, detection of abnormal conditions in the mother and child, procurement of medical assistance, and execution of emergency measures in the absence of medical help. She performs an important task of counseling and education, not only for the woman but also within the family and the community. Work should involve antenatal education, preparation for parenthood, extend to certain areas of gynecology, family, and childcare. She may practice in hospitals, clinic, health units, domiciliary conditions, or other services. Treat complications due to miscarriage or unsafe abortions. Recognizing and addressing problems in women and newborn before, during, and after birth. Offering general health information, including reproductive health care and planning. Assisting women to successfully breastfeed. Referring women and newborn for a higher level of care when the complications arise beyond their scope of practice and capabilities. This principal objective of midwifery profession is midwife should uphold the dignity and honor of profession and accept of its self-imposed disciplines. Midwife should provide quality, culturally acceptable care to keep the woman and newborn safe. In countries with strong midwifery services, midwife play an important preventive role by offering immunization, health education, family planning information, and promotion of many aspects of healthy lifestyles. Midwife can also foster dialogue with the female community leaders about needs of pregnant women and ways of mobilizing support for them. Professional midwives can build their relationship with their community. Often they have traditional birth attendants, although TBA do not have training to deal with life-threatening complications of their cooperation can be helpful in convincing families of benefits for professional care, early referral or institutional delivery when complications arise or seen early. Diameters of gynecoid pelvis. The brim and posterior diameter is 11, diagonal conjugate 12 to 13, and right oblique is 12, left oblique is 12, transverse diameter is 13, pelvic cavity is 12, pelvic outlet is 13 cm, and oblique diameter is 12 cm, and transverse is 10 cm. Minor disorders of pregnancy in the first trimester include breast changes, urgency and frequency of maturation, malaise and fatigue, nausea and vomiting, thylism, gingival hypertrophy, nasal stiffness and epistaxylochorea, psychosocial, dynamics, mood changes. Second trimester, pigmentation, supine hypertension, foot cravings, heartburn, constipation, varicose vein, headache, back pain. The third trimester, shortness of breath, insomnia, leg cramps, and ankle edema. Stages of labor. There are 4 stages. The first one is the beginning of true labor pain till the full dilatation of cervix, otherwise called as cervical stage. The average duration is 12 hours in primary and 6 hours in a multiparous woman. The first stage have 3 phases: active phase, latent phase, active phase, and transition phase. Latent phase up to 3 cm, active phase 4 to 7 cm, and transition phase is 8 to 10 cm. Second stage start from full dilatation of cervix to the delivery of the baby. 2 phases. Propulsive stage start from the full dilatation. Expulsive stage and average duration is 2 hours. Third stage begins after the expulsion till the delivery of the placenta. Average duration is 15 minutes both in primary and multi. Characteristic of lochia. Early in puerperium, slugging of decidual tissue, vaginal distal and variable quantity. It consists of fatty epithelial cells, membranes, decidua, and blood. Lochia rubra. With first few days after delivery, blood sheds of fetal membranes, decidua, vernix caseosa, lanigo, and meconium in lochia. Lochia serosa, more brownish in color after 3 to 5 days, become progressively pale in color. Lochia alba, after 10th day, white or yellowish white color, lasts for approximately 2 weeks after delivery. The significance: if the order is offensive, it indicates infection. Amount is scanty or absent or excessive, indicate infection. Color: persistent lochia rubra beyond the normal period, signifying subinvolution or retained bits of conceptus. Duration: lochia alba beyond 3 weeks, there's local genital lesion. Differentiate between first pelvic dip and second pelvic dip. Using thumb and fingers of one hand, lower the portion of mitre is known as the first pelvic dip. With the tip of the first fingers and hand, expert deep pressure the adduction axis of the pelvic inlet is the second dip. Difference between true labor and false labor. True labor contraction follow regular pattern, but the contraction rarely follow a pattern. Contractions become close together. Contractions get stronger with ambulation. Contraction seems to start in lower back. Contractions not stopped by controlling breathing. Cervix often effaces and dilates. Fetus continues descent into the pelvis. Contractions rarely follow a pattern. They vary in length. Contractions frequently stop with ambulations. Contractions eventually stop with relaxation intervention. Cervix may be softened, but little or no change in effacement or dilatation. There is no significant change in fetal position. Menorrhagia, metrorrhagia. Menorrhagia or hypermenorrhea is cyclic bleeding of regular intervals. Bleeding is either excessive or duration or both. Causes are pelvic the fibroid uterus, adenomyosis, pelvic endometriosis, IUCD in utero, chronic tuber ovarian mass, tubular endometritis, retroverted uterus, granulosa cell tumor. Metrorrhagia defined as irregular acyclic bleeding from the uterus. Amount of bleeding is variable. Metrorrhagia may be a sign of underlying disorders as hormone imbalance, endometriosis, uterine fibroid, or less commonly cancer of the uterus. Biophysical assessment in early pregnancy, it includes USG estimation, crown rump length, and neckal translucency. Late pregnancy, it includes CTG, NST, BPP, Doppler ultrasound, contraction thrusters, USG, amniotic fluid volume, vibroacoustic stimulation. Abnormalities of placenta, bilobe placenta, circumvallate placenta, and succenturiate placenta. RH incompatibility, it is occurring during the pregnancy when an RH negative mother pregnant with an RH positive baby. If one person have RH factor, that means the RH positive. RH incompatibility occurs when the pregnant woman whose blood type is RH negative is exposed to RH positive blood from the fetus, leading to the mother development of antibodies. These antibodies have potential to cross the placenta and attach fetal red blood cells, resulting in hemolysis or destruction of the fetal red blood cells. The most severe form of erythroblastosis fetalis, the progressive hemolysis causes fetal hypoxia, cardiac failure, generalized edema, eye drops, and effusion of pericardial, pleural, and peritoneal space. Fetus may be delivered stillbirth or in the severe respiratory distress. Maternal RH immunoglobulin administration, early or intrauterine detection of alloimmunization by ultrasonography and chorionic villus sampling, and subsequent treatment by fetal blood transfusion have dramatically improved outcome of affected fetus. Thank you.